We have Dr. David Margolius from Cleveland MetroHealth giving us tales from the COVID hotline. And I'm going to see if I can speed up my slides here. And 2 weeks from tonight, we have Grassroots in International Climate Response, Some Ways Forward with Dr. Frank Granshaw from Portland State University. 2 weeks after that, we'll have Dr. Warren Allman giving a Darwin Days related talk. And I think I'm going to go ahead and hand it off to David. And in the interest of full disclosure, I will also note that David is my nephew. Dr. David Margolius from Cleveland MetroHealth is going to be talking about the experiences of manning and coordinating the COVID-19 hotline for Cleveland MetroHealth. So take it away, David.
Great. Thank you, Uncle Don. Would have come out as the disclosure, pretty quickly, but thanks all for joining. Hello, family and new friends. Let me know if I need to speak up at all. I'm just a room away from a sleeping 5-year-old and 3-year-old, or almost sleeping 3-year-old and 5-year-old.
Sound fine.
Okay, sounds good. So I've got about 30 minutes planned with you today, and then really want to open it up for a lot of discussion, because while I feel that the development and implementation of the COVID hotline might be the most fascinating thing about COVID, there's a lot more to talk about, and I'm happy to talk about all things related to COVID-19, where we were, where we are, where we're going, all that sort of thing. Okay, let's see. There we go. So I put together learning objectives because for medical conferences, and I'm sure science education conferences, you need these learning objectives to get continuing education credits. But in general, what I'm going to do is tell a story about what happened last March and how we developed this COVID hotline that has continues to this day. In fact, it's pretty much at its busiest as of today, unfortunately. But I'll talk about really what we did, what we went through, how we were able to succeed, why it mattered, and I'm going to do it in a novel format with a prologue, 4 chapters, and an epilogue. And as I'm talking through this, there are really 3 themes that were the foundation for why we were successful. And I hope it resonates with anybody who's worked in a somewhat dysfunctional, archaic, out-of-date system like healthcare or education, or insert fill in the blank. But the three ingredients that made this huge change successful were executive urgency. So the CEO of the organization said, "We will build this," and that drove everything. Had that not happened, we wouldn't have been able to do what we set out to do. As we were building this and maintaining it, we had psychological safety. So there was really around the clock, no judgment availability. There was a regular email cadence. We had daily huddles. We had daily captains. So it was a distributive leadership model where everybody participated in making it better. And third, and I think most important, was we had purpose. We really felt that this was our opportunity to serve. And as we were recruiting people to build this 24/7 hotline, that purpose really kept the fire going. So these are the 3 ingredients that I'll come back to at the end, but sort of listen to them throughout the presentation. And I think that
may be interested in this online webinar. Oh, did I shut it off?
I thought that would have been a good question. So a little bit about us. MetroHealth system in Cleveland. We are a county subsidized healthcare system in Cleveland, Ohio. Cleveland, as many of you know, is one of the poorest medium to big size cities in the country. And so we are the county system. We take care of everybody regardless of their ability to pay. Our mission or our vision is to be the most admired health system, public health system in the nation, renowned for innovation, outcome, service, and financial strength. So community health, improving the health of everybody regardless of their ability to pay is what we're all about. We have one big hospital, two small hospitals, 25 clinics, and we take care of about 300,000 individuals a year. About half of our patients are Medicaid and 4% are uninsured. It was 25% uninsured until 2014 with the Affordable Care Act. And so now it's about 50%, 40 to 50% Medicaid and just down to 4% uninsured. Thank goodness. So on March 9th, this is when really everything changed. It was a Monday. I'm sure many of you remember where you were this week or the week before. For us in Cleveland, March 9th, Monday, was the date of the first 3 cases diagnosed in our county. If you remember that week, March 11th, that Wednesday night was I think it was the weird NBA game where they came onto the court and then something happened and everybody left the court and they had everybody leave the stadium because it turned out one of the players for Oklahoma City, I think, had tested positive. And so things were getting, really tense and scary this week. Our CEO that Wednesday told the leadership team that we would launch a 24/7 physician-staffed COVID hotline by the next day. So we would have physician on call 24/7 taking calls by the next day to handle anything related to COVID. So 2 days later, March 13th at 11 a.m., we did launch the COVID hotline, and I'll walk you through that in the prologue here. When we heard this edict from above, the first thoughts were, where are we going to get anybody to staff this hotline 24/7? We technically have physicians on call 24/7, but when I'm on call on a typical night, I might get a couple pages between 5 and 7 p.m. And every 4th or 5th night at like 1 a.m., I'll get woken up with something. But that's it. We don't have physicians ready to staff a hotline around the clock. So who are these people going to be? How are we going to incentivize this? This COVID, as far as we didn't really exist for us prior to that month. And so how many calls are we going to get? What is this? What is this going to become? And then it's a hotline. Are we going to do video visits, or are we doing everything over the telephone? And then how are we going to pay for this? So all those thoughts were running through our head. This was how things went down. The CEO there on the top left told the Senior Vice President of Population Health, make this happen. The Senior Vice President of Population Health told the Medical Director of Population Health, the Director of Telehealth, so the guy in the middle all the way to the left there, Albert, above my picture, had been hired in like October, 6 months prior, to run all of telehealth for MetroHealth. And he had been walking around, sort of meeting with people, trying to talk physicians and staff and patients and anybody who would listen to him that telehealth was going to be a really big thing in 2020. And we all kind of, laughed and said, sure, yeah, like any of us are going to, do that. So this guy, he was involved in this. And this became, his shining moment. Kathy Spivak in the middle is billing, me and some docs there you see on that row. Over to the right side, we have the director of our call center, a supervisor in our call center, a lot of folks from information services who knew how to build schedules, create workflows on the back end, which I'll talk through just a little bit. there are folks, the nurses, two nurses there, Crystal and Suzanne, all the way out to the right were our lead administrators and folks behind the physician enterprise who helped us figure out like the billing side of things. And so first thing we did was we got a phone number, 440-59-COVID. So you can call that really from anywhere in the world. And we got calls from all over the world, which was interesting. The workflow was you call the number and says, hello, you've reached the MetroHealth COVID hotline. If you'd like more information about COVID-19, press 1, and we would have someone sort of talk to a scheduler who would refer them to the Board of Health. If you believe you have signs or symptoms of COVID-19, press 2. That call would go to a nurse who would then set up the individual calling with a doctor about 10 to 20 minutes later. And then we set up some other numbers down the road, but that was the workflow we set up. We built a template, a schedule into our computer system, which is called Epic. And we put it all under this place called Westlake Express Care because it used to be a clinic that disappeared. Created a billing code, which unfortunately is, you can't do anything in the computer unless there's a billing code behind it. We recruited a physician workforce, which I'll show you a little bit of that, which is basically me shouting help. And on the back end, I created a schedule for everybody to sign up for shifts through a doodle poll, which I'll show you a picture of that later on too. And then there was a lot of communication, a lot of tip sheets, emails, and advertising. And so tip sheets were basically these PDF files that showed step 1, this is what you do, step 2, this is what you do, and this is where for the clinicians to do this entirely new workflow that we had invented overnight. This is one such tip sheet. So this is what our computer system looks like. And you know, unfortunately, most hospitals in the United States use this. This is called Epic. So you'd see the schedule, you'd see the patients lining up in a queue, you'd right click on the patient, you'd say change provider to me, and you'd pull the patient off the schedule. And that's how you'd begin your visit on our end. So we built all that. That was, you know, Wednesday we heard the announcement. Wednesday night was our first meeting. Then Thursday, 7 a.m. meeting, 12 o'clock meeting, 5 o'clock meeting. And then Friday, we were ready to go. And it was me as the only doc at that point. And I'd signed up someone for the overnight shift on Friday and had someone ready for the Sunday shift, I think, but that was it. So I sat down, I was at home, I was in this room, and I did my first visit, and I realized that I didn't really know what to write in the chart. I mean, we got a call from a person who had an upper respiratory infection that absolutely could be COVID-19. You know, we had no idea. And so just to demonstrate the kind of teamwork that we had developed from that large picture with all those faces, so I sent this email at 12:04. I said, I did a visit. I need a way to write a note. Can someone create a dot phrase for me? So I type in that expression and a note pops up. And 5 minutes later, someone created the dot phrase, was working on a letter, and just doing amazing things. And I think you can see the timestamps on there of how quickly things were happening. So for me, this was extremely thrilling, and because I've never worked in an environment where things had happened so quickly, and so that was pretty cool. So going back to those challenges that we had anticipated, who will staff the hotline? Maybe we'll get lucky with people just signing up. You know, good heart. We're paying decently, so we create an incentive that would be $500 for this 12-hour shift, $8 a call if you take patients when you're not on a shift. How many calls are you going to get in that $500 12-hour shift? We have no idea. Telephone or video? We decided telephone, and I'll show you why in a minute. And who will pay for the hotline? Well, we took it out of operations, and later on we applied for a grant because we built this as really as a free 24/7 hotline. So why telephone versus video? I'm sure by this point in the pandemic, folks have had the chance to have a telehealth visit with their primary care clinician or otherwise. There's telephone and then there's video. The video technology, if everything's working perfectly, it's kind of cool to for me seeing my doctor or me seeing my patients. But you have to have good internet to be able to do that. And in Cleveland, where it counts, there isn't good internet. And so this is a map of Cleveland on the left, which shows the historically redlined neighborhoods from the 1930s, which were how banks determined the value of property. And they basically used whether or not there were African Americans in a neighborhood to determine the value of neighborhoods. And this is a map present day of where AT&T and other internet companies didn't invest in the infrastructure to bring in high-speed internet. And so to this day, if you live in a neighborhood that was redlined in the 1930s, it's still pretty impossible to get high-quality, high-speed internet. So me being the hippie I am, said that we will not be doing video visits. Everybody's doing telephone visits because that's what we're gonna do. And so for now that has stayed, although every couple months there's another meeting with an executive who's trying to push video visits because the reimbursement is twice as high, unfortunately. So that brings us to March 12th. And going backwards a day, the night before. So I emailed some folks, and I'm just going to move here we go. So that first night I blind copied everybody who was emailing because, I didn't want any reply alls, and you know how that goes. And I said, all right, here's the story. I really, I need some help. I've got someone signed up for Friday night, but please help. At this point, the entire state was locked down. I mean, everybody was scared. It was a really tense time. Here are the types of things that we're going to be dealing with. The folks are going to call with respiratory symptoms, or they're going to call with just scared of everything that's going on. And generally, you're going to reassure them, but if it sounds like they could benefit from some medicine, like some asthma medicine or cold medicine, or if they're sicker and you think they need to go to the emergency room, then that's what you should advise. And so that's basically what we're doing. Okay, so day 2. All right, folks. So we've done 57 appointments so far. It's Saturday. I think this is Saturday AM when I sent it. 9:49. As you see, there's about 25 people I'm emailing here. And here are the types of things that we're seeing. Can other folks join on? All right, okay, it's Sunday now. So we've done 183 appointments. Most people are calling with respiratory symptoms, which is like cough, cold, runny nose. A lot of folks now are calling for testing because Cleveland Clinic and University Hospital, the big hospitals across town, have opened up these testing sites where they have these like 6-hour waits in a car to drive up and get a test. And so people are going to be calling for that order, and that's not something that we can do. And now it's Monday. Okay, guys, there's a 3-hour backlog of patients on the hotline. I need everybody who's seeing this email to please sign on and pick up patients because we're falling behind. So Tuesday, this is day 5 of the hotline. Now my group has grown a little bit. So you see in the top of the email, I'm up to 60 or so emails. So the 15 you see plus 48. And as of 5:40 p.m. today, we've done 244 doctor visits in this one day. We did 255 in 24 hours the day before. So you remember that first day we did something like 30, and by day 2 we had done 50 or 60 visits. So everybody, please sign up. We need your help. We're here. I've attached some tip sheets, and here's the kind of things that we're dealing with on the hotline. A couple days later, I've got a little bit of a bigger group. And by the way, the CDC has changed their guidance on how to treat COVID. So here's an update on how long you should stay home if you have some respiratory symptoms that you think might be COVID. And the next day, my email is getting a little bit more organized. Tried to highlight some of the change points and where we need more shifts. And my group has grown to almost 100 at this point. So that was the first week or so, and it was pretty intense. I'm going to drink a sip of my beer here so I can, as I'm remembering that time. So what I did to staff this was basically create shifts on shifts on shifts. So every day we had a 7 a.m. to 7 p.m. shift and a 7 p.m. to 7 a.m. shift. And then as the volume was going up and down, I would add 4-hour shifts kind of overlapping on top of that. And this is what it looks like today, or January 11th, with this doodle poll that I created, and basically keep updating. So I go back and delete the old dates and just add future dates and add future shifts about 2 to 3 weeks ahead of time, which is not something I don't know if Doodle was designed to be used in such a way, but that's what we decided to do to get coverage. Anytime a queue was building up on the hotline, so if it was more than like 10 individuals kind of waiting to be called by physicians, I would write an email, reply all to 100 people and say, please, anybody who has a free moment, please jump on. And that's how we got through those first 2 weeks and the subsequent surges. Over time, we've created the right kind of shifts to reduce those emails, but unfortunately, all those clinicians were victims to my large reply all emails a few times a day as we were getting through this. And generally, we were exhausted, not sleeping, taking these calls, talking to appropriately worried person after worried person, sending some people to the emergency room, keeping some people at home, and just checking in on them every day. But in general, we didn't have tests back then. And the only thing we could tell people to do was to quarantine at home. So this article is from March 16th, 3 days in, and we had told 200 people that they needed to quarantine. And I had had some conversations with executives in the hospital who said, you're telling these employees that they could have COVID and they should stay home. And I said, yeah, if you were hearing what I was hearing, you'd think everybody has COVID right now. And they said, well, you can't tell people that. We need people at work. And it was these hard conversations that I was having. And essentially I was able to get enough support and stick to my ground. But it was an incredibly an emotional couple of weeks. And then on March 23rd, in Cleveland.com, which is what has become of our local newspaper, one of our clients who had called the hotline wrote this article. And first person article, she is a social worker at the VA. And she was one of the folks that called, and she said, she started the article, "We are the presumed, the uncounted that will never have our experience validated." On Saturday evening, March 14th, I began to feel ill. She had all these symptoms. She was extremely worried. She called our hotline. And she felt really supported. She goes on to write about how much it meant to her to get these follow-up calls to make sure everything was okay. Her husband had similar symptoms and called and got similar advice. but it was just so gratifying to hear that even though it felt like we were giving so little, that she felt the support of our network and recognized the kind of precarious situation of being the presumed, and really described the moment. And I think there were a lot of folks back in March and even into April who had the similar experience where they were the presumed, like they had symptoms, but there was no way to get a test back then. So the next day, so I read that, cried my eyes out. The next day, our healthcare system started this, not the next day, our healthcare system had started this podcast over the years. And the next day they interviewed me for this podcast, and I'll just play one clip that they turned into a video where I was interviewed in this room.
We don't have the sound, Dave.
Bummer. Okay, so what did I have to do? Let's see, stop share.
Stop share and then restart, but click the share audio at the bottom of the share screen.
Okay, you told me all these things. So I should stop share and then restart share?
Yeah, and before you start,
you told me all that, okay. All right.
Something happened last night that just hit me so hard in a good way. So there was this, I don't know if you saw this on Cleveland.com, one of our clients, one of our patients who called the hotline, wrote a piece about her experience. And it just, I just read it, and everybody was asleep in the house, and I just read it and just broke down crying. I mean, it was so powerful, and it just made it feel like it was all worth it. You know, I mean, just everything she wrote, and that how grateful she was for the service, and that, you know, she called, her husband called, just to read her story. It just made it feel like it was worth it. It's been worth it.
So that, yeah, so that was the time of type of thing that really, you know, made it made it worth it. Not only reading her article, but also it was nice to get, you know, professional MetroHealth podcast crew to do something like that, and basically, you know, share with friends and family, like, all right, this is what I've been doing the last 2 weeks, like, you know, pretty wild. So that was chapter one. Chapter one is the longest chapter, by the way, so I recognize that I promised you 30 minutes and I'm 23 minutes in. But that was kind of the routine, and you can see this is our average count here per day. And that biggest day there was at, I think, March 17th, and then started to slide down. The annotation there about the restaurants and bars reopening and the daycare reopening are not my annotations, but they're kind of funny. So this takes us into the end of April. But I basically worked into a routine. We had a daily huddle. I still have a daily huddle every morning at 7 a.m. on weekdays, where I talk to the 3 or 4 main docs and the nurses who are answering calls, and kind of go through the latest updates. I send these email updates because the CDC guidance was really changing pretty frequently at the beginning, and just what we need to know, the types of calls that were coming in. And I was reviewing really every single chart just to make sure that the new docs that we were recruiting weren't, you know, we're doing the right thing, and we're given the type of care that we expected. So chapter 2, a little bit of a different tone. Got a couple phone calls while on the hotline towards the end of April, early May. One of the residents at this congregate living facility, a group home where disabled adults live, has tested positive. MetroHealth, can you help? And then later, a congregate living facility, assisted living in Beechwood, similar call. So one of those first calls actually came Friday night, like 5 p.m. And I walk into my boss's office, who's the chief quality officer, pictured there. And I said, this is, how are we going to go to a place outside of our hospital and test people? There's no way, right? And she said, well, you're right, but we should figure out how to do it. So that Tuesday, this is a picture from our group who went and we did some testing in a group home, and it ended up worth it because folks were positive, obviously, and we were able to figure out how to isolate folks and stop the spread back then. And so that turned into an even bigger thing. We ended up signing a contract with our county to do all of their testing for group homes, homeless shelters. We set up in church parking lots. We worked with community organizations, inpatient addiction treatment, the jail, the county jail, which was, that would be a whole nother chapter some other time, and nursing homes. And since that day, we've done about 14,000 tests in these different environments. To scale that, we've done 40,000 tests total as a system. So we've done 14,000 in these different environments. So that was chapter 2, and that was a fun chapter. Chapter 3. So you may have heard of proclamations like this one. So our governor also said, anybody who wants to get a test can get a test. And we said, oh, that's news to us, the testers at the hospital, who maybe you could have told that beforehand. So he said this was June 11th, and that's, you can see where July 4th is, their Independence Day gathering, but that prompted a surge in calls, in addition to a rising prevalence in our community. We didn't really have a great way to test folks yet. I mean, we had built in some niche-like systems so that we could test police, fire, our own employees, congregate living facility employees, but we came up pretty quick with a system to test our folks. And I sent an email June 22nd. I said, well, you heard the governor, let's test everybody. And then I got called to the principal's office and sent an email shortly after and said, yeah, but use your judgment. You know what I mean? Just, to walk that back a little bit. Basically, the principal told me that, and I'm sorry for the principals in the audience, the principal told me that we will not be running a retail testing center. We will use our judgment and, preserve our tests and yada, yada, yada. So how did we do these tests? So same challenges. Where were people gonna go to get a test? What's the workflow from the time I order a test to when the test is performed? What's the longest acceptable wait from order a test? So if you have symptoms on Tuesday, does it even make sense to do a test on Friday and get your result on a Sunday? And really, how many tests can we do in a day? So we created another tip sheet, and we built a system where when I order the test, or when any of the hotline clinicians order a test, it goes to a queue, and someone at our call center, which is a staff of like 10 high-performing folks, start working that queue and calling people to schedule tests. So we did all our tests through appointments in drive-up facilities. So in Cuyahoga County, we have about 25 different locations. We picked 4 that were at different corners of the county and 1 in the center, 3 corners, one center. And we deployed some of our nursing staff out of the clinic and out into these tents to do these appointment-based testing. So you basically get a call, you'd make an appointment, it would be within a day. That was what we deemed acceptable. And you would drive up to Cleveland Heights, drive-through pictured there, roll down your window, tilt your head back, someone would stick this up your nose for 5 seconds until you were crying. And we would call you, or you'd get your result through an email within 12 hours about. This system worked so well that it's really 70% of all of the non kind of outreach testing that we were doing was done in this manner. So there was a little bit done in our urgent cares, a little bit more done in our emergency rooms, but for the most part, this is how we were doing all of our testing, a great majority of our testing. So that was chapter 3. That was the system that we had set up. We managed to get through that surge in July. And then we were doing really well. There was even another call to the principal's office where they said, all right, we're ready to turn this hotline into a virtual 24/7 urgent care now that you've conquered COVID. And I said, can we wait till November? And seriously, and we did. And then all of a sudden, so you remember that in March, our high in a day was something like 270. And you can see now where we are in December and January, which is that high hill all the way to the side. So we got a day up to 400. And right now we're usually doing about 250 a day for the last couple of weeks. And so I wake up and go downstairs and have my coffee and download yesterday's doodle schedule and email it to my friend Kim. And I review the previous day's visits and tinker with the schedule a little bit. I have my daily huddle with some of the star doctors on our team and one or two of the star nurses. These are some things on the back end where we made the hold time a little bit shorter. So we removed the RN part and just said, well, you're going to talk to the doctor either way. So we'll just, put you on the line with the clinician after we list your symptoms and a little note. And November 20th, we went from physician only to include nurse practitioners as well, which nurse practitioners are incredible. The only reason we were physician only at the beginning was because of a marketing gig. And so it was nice to finally free ourselves from that and, let the whole team play. In general, what we saw was that, so the orange is the number of calls per day on the hotline. The blue correlates with the y-axis over to the right, and that was the number of patients in our hospital who had COVID-19. And incredibly, it really just seemed to track together. And the hospital uses the COVID hotline volumes to predict when they're going to need to open up new hospital wards and close down clinics to pull staff into the hospital, which is what they're doing right now. And our positivity rate, which is, you can kind of see by the green Y bars there, just has risen and risen. So when things were going well, our positivity rate was less than 5%, and we were hovering around 3% for a long time. Then in December, it climbed up to about 35%. And now it's about 25%. So 1 in 4 tests that we send come back positive, which would be extremely alarming and nightmare inducing had it not been 35%, last month. And so we're like sort of relieved, but it's still incredibly high. And of course, in winter, an exciting thing happened. That's not a stock photo. That's a pharmacist I work with who is administering a COVID vaccine. So that we haven't yet seen the effect of that in our community, of course. But as of 3 or 4 days ago, I went from calling 10 to 20 positive employees every single day to 2 or 3. And the 2 or 3 had not yet gotten their vaccine. And that change happened like Monday. And so even for the first 2 to 3 weeks after getting the vaccine, people were still getting positive as expected, because the vaccine doesn't kick in until at a minimum day 14. But now we're seeing that folks are finally turning up negative. So that's exciting. And I have one more video, if that's okay. It's a 4-minute one. It's kind of a nice summary of everything that I said.
Hi, this is Dr. Milliner calling from Metro's COVID line.
Hi, this is Dr. Dave Margolius calling from MetroHealth.
Hi, this is Dr. Dardier from MetroHealth from the COVID line calling regarding.
So I understand you've had a headache and fatigue and learned that someone you were with over the weekend tested positive. Okay, you're at a wedding, you said? So Monday, March 9th was the first 3 cases in Cuyahoga County. And it's kind of when everything changed. I mean, I think the week prior, we
knew bad things were coming and big change was coming, but it wasn't until that Monday. And by Friday at 11 a.m., we had this full-time 24/7 physician nurse run COVID hotline.
Okay. What other symptoms does she have other than the congestion and loss of smell?
That first day, I think we got something like 30 doctor visits that we did over the phone, and maybe twice as many calls that came in and had just spoken to the nurse. And then pretty quickly that next week, I think we were up to like 150 visits a day. I send this email out to 100 docs and say, whoever's available, anybody who has a free 15, 20 minutes, please sign on now. And immediately 10 docs will sign on and come to the rescue during these surge times.
Waiting to be seen today at this minute is 15 that need to be called. And so far today, we've taken already 168 calls, and it's not quite noon.
The work that we were doing over the phone was more than just diagnosing, here's what you have, here's your treatment. We spoke to people who were the first people to be positive in their place of work. I remember speaking to a fireman who was the first positive person in his station, and he was just so concerned for his work family. Essentially, what would they think? What are they going to do? What's this mean for our community? And so much of our job was saying, look, you're going through this for the first time. We've spoken to lots of people who have gone through it for the first time, and we can help. And so that was a big part of that continues to be a big part of the work that we do.
Just being able to fill in a need that wasn't there before and feel like you're making a difference, even if it's not a difference to everybody else, at least it's enough of a difference for me that I get up and do it again the next day.
Do you feel like the shortness of breath is getting worse? Okay. What has driven this work is just the opportunity to make an impact with this global pandemic has just been a driving force for us.
So you have some concern about some COVID symptoms?
Just lots of rest, lots of fluids, keep a very low profile, bond with your family, because I'm sure that's what you're really looking forward to.
For the docs on the hotline, for me personally, just the opportunity to be a part of this, to help people who are in a bad spot has been really rewarding. Well, let us know. We're right here with you, okay?
So you can call us back anytime. We're on 24/7. If you have any other question or things change, call us back.
Okay, stay safe. I hope you feel better.
So that's I probably could have just played that video and saved yet some time, but hopefully it all sounded familiar. So that was the hotline and continues to be the hotline. And going back to the beginning, these were the three things that really, I think, have made it work. The executive urgency, so knowing that you have this support and this fire lit kind of where everybody in the system is working together to get something done. Psychological safety, where we really built a team where people felt safe around each other, even when we couldn't be around each other. And then, of course, purpose was a big part, and we would have lost had we become a 24/7 kind of virtual urgent care, but we kept it COVID, and I think it really made a difference. And with that, I will stop sharing the screen.
Awesome. That was great, David. Thank you.
Thank you.
So we'll open it up for questions, and I'll note that Glenn, at least one of our Canadians, I don't know if we have more than one, noted that in Calgary we have 811, their HealthLink service, with an LPN on call, and the nurse will triage and determine if you go to the ER, walk-in, or drugstore, and they will even set up appointments where convenient, and it is free of charge because it's Canada.
Yeah, and it's only 3 numbers instead of 10 digits, so it's even better. Yeah, that's
Yeah, it really has stunned me how much it makes sense from all points of view. Like from my point of view, if my daughter swallowed a ball bearing from a game, And so I was like, what do I do? Do I go to the emergency room? Do I go to a walk-in? Do I just let her poop it out? You know, so I called the nurse, and then the nurse said, well, she had a lot of questions and directed us, and everything ended up working out in the end. But to be able to do that, you know, is yeah, just so convenient and so easy. I will say that when the COVID, now that we're in this COVID thing, so that's just normal time, but during COVID, it was very difficult. They would have a message that said, right now the wait times are so long that you just have to call back, you know. So I appreciate your trying to make sure that the wait times aren't so long, that people can actually get someone on the other end of the phone, because that's, I mean, that's why we're calling to begin with. So that part has been a little frustrating, but thankfully we haven't had to use it that often either. So.
And there's another question. Do hospitals already have pandemic response plans or surge capacity response plans in place, or were these developed as the situation unfolded?
Yeah, so we definitely had plans and people and a crisis manager and things like that, but none of them were really relevant to the situation, other than kind of like having the extra staff on call. So everything was developed as the situation unfolded. And it really was so dependent on, because there was no federal leadership, it was the state in our case, and I'm sure in New York and elsewhere, that kind of dictated what that looked like. So the state said to us that we had to figure out how to triple our capacity by the end of the week, you know, in 4 days or something like that. And so we had to create a plan that had spreadsheets of, here's where we're going to pull all the staff, here's where all those or the beds are going to be, and be ready. And thankfully, we never had to use that, but it was every day there was a new kind of demand coming along where we had to build these things from scratch.
I had a question.
Go ahead.
Is that okay? Can I?
Yes,
I just thought I'd say it. Sorry. So I noticed the 3 steps. When you talk about the executives and the support you got from them, like, did you guys ever have a situation before this where the executives, like, I guess my question is, how were they able to be so freeing to let you guys move forward and be so supportive? Like, had they ever had a situation like this before?
Yeah, it's a great, right? Like, what are executives normally doing? And I think, you know, I think the frustration for many of us on the front line, and all of our workplaces, is we always have, you know, great ideas or hear of great ideas, and we think, well, we should get that done. But without what was unique about this was, it was the great idea was the CEO's idea, or he had, you know, heard it and then championed it. I know that the CEO always comes up with ideas and pushes them on people, and a lot of them don't stick. But this one was a good one, and we were able to establish a purpose around it and build kind of momentum around it and really run with it. And I think that was what was unique about this.
Yeah, it's really cool. And one follow-up question: are those your parents?
Yes. Yeah.
Well, the name, I thought that's pretty cool.
Yeah, one of my favorite things about this is that there's almost always a adult child and their parents.
That's pretty sweet. Well, thanks. Great chat. This is awesome.
Thanks.
Really great work.
Thank you.
And Rob had a question. Have you had enough beds and respirators throughout?
Yeah, we have. Yeah, we only recently had to close 6 of our 25 clinics to pull staff into the hospital. And that was because the community prevalence has gotten so high that so many of our staff have had to call off because they have COVID. And so we had to pull staff from other areas. But we never had the threat of not having enough beds or ICU beds.
That's good. And what are numbers doing in Cleveland now?
It's still really bad. It went way up here, and now it's maybe a little bit lower, but it's still, I would call it a plateau. Our positivity rate is 25% right now. And so the best kind of judgment of what the prevalence in the community is our pre-op testing, because we're just testing kind of random people who are just scheduling surgery without symptoms. And it's about 1 in 20, 1 in 15 to 1 in 20 right now are coming back positive.
Yeah,
it was like, yeah.
In Buffalo, I'm worried about the after effects of the Buffalo Bills doing well.
Yeah.
I know we're getting together, and I don't know if they're doing it smartly or not.
Yeah.
Yay, go Bills, but be careful.
Right. And you won't see it for six to 8 weeks, unfortunately, because of the way it ripples.
And a couple more questions. What do you think caused the spike in November?
Boredom, I think, and not. People got sick of the public health messaging, basically, and said, "Well, this isn't that bad." And that started to happen towards the end of September into October, and it hit the numbers in November. We did this all summer, we did this all spring, like enough already. I'm not seeing any of the consequences around me, and it's human nature. Nobody to blame, well, other than the federal government, but that's what caused it in November.
Yeah, and of course, people couldn't hang out outside either as much.
Right.
And another is the hotline absolutely swamped on the weekends when doctors' offices are closed? Yeah,
interestingly, holidays and weekends are lighter. So you kind of saw it on that, if you could see it on that bar graph, but weekdays are like 200, 250 right now, and weekends are 100, 100. And then Christmas and New Year's Day were a little bit less than 100, I think. Because people just assumed we'd be closed, I think.
Okay. And I am wondering about the vaccine. I received my first round Tuesday, and I am scheduled for my second round February 9th. We just received word that our county has canceled recent appointments due to lack of vaccines. If I miss my date due to lack of vaccines, will that be okay?
Yeah, definitely. And that's a strategic plan that we're going to do with the Biden administration too, which is release all the vaccines and not hold back the second dose and just assume that they're going to continue to manufacture. And the reason is because you get that first vaccine, 14 days later, you already have some protection. The week after, you have more protection. And there is a minimum time between when you get the first and the second, but there isn't really a maximum time. We might say a maximum of 6 months, just to say it. But as long as you get that second vaccine sometime after, it's going to be helpful.
And yeah, and Bruce says thanks. And I'm going to read the next two out of order because Ken's is more of a follow-up. Will waiting reduce efficacy?
No, I don't think so. We don't know for certain, but I don't think so.
Okay. And Pat's is more of a comment. It seems a shame that it appears from the charts that we had COVID almost beat, then got lazy and lost ground.
Yeah. The way to have beaten it would have been more testing, and everybody in the country to be able to test themselves at home every week.
Yeah.
And we could have done that, but there was just there was someone saying no, less testing in the White House, so that made that hard.
Yeah. Do you want to look into your crystal ball and take a guess at when I'll be able to go to a concert again?
I think that the summer is going to be looking good. It's never, at least I'm never going to be the same and feel the same and do things the same way I've done. But I think I'm excited about the summer.
Yeah.
I think we can really do this. Vaccination for kids won't be available for some time, but many of you, I'm sure, have read the New York Times article about it just becoming a kind of a Newsome childhood illness and not being that big a deal for kids. So I think we can do this and sort of get ready for a nice summer.
Yeah, that's kind of what my crystal ball was saying too. So it's good to hear that it agrees with yours.
Yeah.
And Thea and Eric ask, could we have done that? Which I think is referring to the everybody testing at home.
Yeah. Oh yeah, absolutely. For sure. These tests are, it would have been easy to manufacture. There are so many different kinds. The rapid tests aren't perfect, but they're really more than good enough, and we could have done that.
And Teddy asks, if people aren't able to get the second vaccine, wouldn't there be a greater chance of mutation?
You know, I don't think so, because when you think about mutation, or at least when I think about mutation, it's like a partial treatment of a infectious disease. And so this isn't really a partial treatment. This is just some people, they're going to knock out the virus and some people aren't. And so I don't think it's going to have that same challenging effect on the virus to cause mutations that like a drug would, that is meant to treat the disease. So and that spike protein where the vaccine is targeted towards seems to be pretty crucial part of the virus. So
But everybody should get their second shot.
yeah, right. I know. Well, this is a challenge. I mean, there was a pretty good, healthy debate about just do one, give everybody one, and two. But I think giving everybody one as soon as possible and then giving two when possible is going to be a safe approach.
Yeah, and I guess the Johnson & Johnson vaccine will just be one shot, right?
Right.
And that testing, I believe, concludes on that at the end of this month, and hopefully they'll be rolling that out very soon. And they said they can produce 1 billion doses by the end of the year. And your dad notes that there will be a difference between a concert inside and one outside.
Yeah, no, I think summer outdoor concerts will.
Yeah. And Pat asks, is antibody treatment available in your area?
Yeah, it exists. We can use it at our hospital. There was a small study showing that the antibody treatment reduced the likelihood of hospitalization in people who had COVID, who had mild to moderate symptoms early in their course. And so it's really tricky because honestly, most people who get COVID are it feels like their annual sinus infection. Or really, bad cold. And so to go and get infused with antibodies from some experimental drug at the off chance that you might have been one of the people who've gotten sicker enough to go to the hospital, and you might be one of the people who would benefit from that treatment, it's pretty marginal. So I haven't been a huge fan of it at this point, but I did get called to the principal's office to try and recommend it more often.
And Patricia asks, why do you have to get the antibodies early in the infection?
I don't know. Probably just pathophysiologically, I think just to get it before it caused widespread problems for your body. But
yeah, get it before.
More specifically, that's just what the trial looked at.
Other questions? Well, I will put a few links in the chat there. There are 3 links in that. The first is to the Science in the Virtual Pub page for what's coming up. And there will be some more talks added in the next week or two to get us scheduled into May. And we can take more questions. I'm just doing this while there was a lull. And the middle link there is to donate. We are a nonprofit who need your dollars to help us do this sort of thing and all the things that we do. And the last one is a link to the Facebook group where there will be a recording of this instantaneously when we're done. And then Thea and Eric, back to the questions. Thea and Eric ask, how do you feel about Biden's proposed approach to vaccine rollout?
So from what I've seen of it, of just unleashing all of them, the first doses, I'm really excited about that. I haven't seen the specifics beyond that.
Other questions?
And I saw Thea and Eric asked earlier about how much of the hotline was reassuring people about their anxiety and versus symptom related. It was so much overlap, but it was a big part of it was helping people with the anxiety. For sure.
Yeah, a lot to be anxious about.
Right, exactly.
Other questions? Comments, smart remarks, requests for upcoming speakers? Yes, thank you all. And that, I'll note that thank you comes from Ken, who was actually the genesis for Science in the Pub, which then we had, 2 sessions, Ken, before we were first forced into the virtual pub?
Nearly 1 year ago today.
Oh, wow. Yeah, I guess so. Yeah. And some nice thank yous in there, and some more specific comments, but they're flying fast. So I'll just let you read those, and we can stay on as long as people want to stick around, or, within reason. It was a great talk, and nicely done.
Thank you. Appreciate it.
Good stuff. Nice comments. See you, Ken.
Very nice.
Good seeing you, Cynthia. It's been a long time. Oh, and there is another question from Uncle Pat. Why do you think is the long term on telehealth? Oh, that's an interesting thing to think about.
Yeah, I think it hopefully is here to stay. Much of it will depend on unfortunately the reimbursement of it. But the equally hard is the culture change, and we have done that. I think that's cemented. Like, when Albert was the telehealth director, was going around trying to meet with people to convince them to do telehealth, and they were all kind of, ignoring his phone calls. So that has changed, and Albert is now a celebrity. So, but basically Medicare has to set a rule that says the payment that we give now for telephone visits will stay even after the public health emergency is declared over. Because at the moment it's tied directly to the public health emergency.
Yeah, there are some interesting parallels between these things in medicine and education, and I think the cultural changes in medicine are probably easier than the cultural changes in education, but there will be lasting effects.
Yeah, interesting.
All in everything, pretty much.
Yes, I have not had a cold and
Yes,
since last March, and that's been really nice.
Yeah.
So I'm not sure I'm excited about going mask-free in clinic anymore.
Yeah.
Hey, David, I have a question for you. What do you see on flu in your hospital this year?
None. Zero.
Right. It's amazing, isn't it?
Yeah. Yep. Yeah, that was we started testing everybody for COVID and flu at the same time in November, and because we had this one infectious disease doc who was thought the sky was falling, and we I think we diagnosed one, and it probably was a false positive. So yeah,
Interesting.
But we've also had our highest rate of flu vaccination that we've ever had. We were 63% last year in our patient population, and we're 70% this year. So I think that's helped too, though not as much as masking and distancing.
Yeah. And Thea asked, as doctor, do you, and Pat points out that wasn't Pat, that was Carolyn. And Thea and Eric ask, as a doctor, do you find telehealth comparable to in-office visits?
I do. I love him. One of the things I've struggled with is I know that there are certain people I take care of who their only social visit out of their house, especially during the pandemic, but really in general, even before the pandemic, was their visit to the doc. And so I think I was overly enthusiastic about telehealth visits and kept hearing from my hey, I really want to see you in person, and didn't fully appreciate that until a few months in, that's what they were missing, that experience out of the house.
Yeah, I can believe that from your grandmother.
Yeah, right.
For one thing. Any other questions or comments? Well, thanks one and all. Great session.
David, that was really inspiring. Thank you. And I learned
you
so
so
much.
Thank you.
Rob is,
Thank you.
Rob is my colleague, by the way.
Awesome. It helps having the inspirational music while the videos play, I think, to really.
I think I'll play that behind everything I say.
Right.
All
All
right.
right. Well, thank you, everybody.
Have a good night.
Thank you
Take
so
care.
much.
Thanks, Uncle Don. Thanks so much for having me.
Mhm.
Thank you. Thanks, Thea and
Bye.
Eric, a couple of our most regulars.
Mhm.
Great to see you again. Have a good night, all.
Bye.
Bye-bye.